Welcome, everybody. Welcome. Thank you for joining us. My name is Felicitas Colombo. I'm the Director of Government and Public Affairs at the America's Health Foundation and Managing Editor at Vaccines Beat. Thank you for joining us for this important and timely discussion titled Chikungunya, Understanding and Mitigating Risk in a Changing Landscape. We are glad to welcome a vast audience of around 200 registered participants from all over the globe and many more watching us live through our Vaccine Speed website. This is a testament of the widespread outreach of our monthly publication. I wanted to extend our sincere appreciation to our sponsors, the America's Health Foundation, Think Vaccines, and Vaccine Speed. We also acknowledge the support from Valneva with their educational grant. And moving into our topic of discussion, we are gathered here because chikungunya has become an increasingly relevant disease, with incidence rates rising due to the wide range of contributing factors. As a result, it has emerged as a significant global health concern, both as an endemic problem and mostly as a cause of severe outbreaks globally. Today, we are honored to hear from leading experts in the field who will provide valuable insights into the complexities of this virus. In the context of the US, of the United States, we will also explore the crucial importance of preventive measures, especially for travelers, as chikungunya remains present in many parts of the world. And without further ado, let me introduce the distinguished panel of experts who will be sharing essential data and perspectives over the next 90 minutes, an hour and a half. We will start with Dr. Enrique Chacon Cruz, the CEO and founder of Think Vaccines and chief editor of Vaccines Beat. He is a pediatric infectious disease specialist trained both in Mexico and the US, with a master's in vaccinology and drug development in Italy, and extensive experience in research for several vaccine-preventable diseases. Dr. Javier Casellas, a founding member of the Latin American Travel Medicine Society and chief editor of Vaccines Beat. Dr. Casellas has more than 20 years of experience on vaccine clinical research and medical affairs within various pharmaceutical companies. Dr. Rebecca Christopherson is an epidemiologist, biostatistician, and associate professor at Louisiana State University's School of Veterinary Medicine, specializing in vector-borne and zoonotic diseases. Dr. Eileen Chang is an associate professor of medicine and microbiology at George Washington University and a clinical translational arboviral researcher. Thank you all for being here with us today. And I will now give the microphone to Dr. Javier Casellas, who will share the basics in acute infection, transmission, and public health impact. Welcome, and thank you, Dr. Casellas. Dr. Casellas, you are muted, so you can unmute your microphone.
Yes, I was having some trouble with the presentation, sorry.
Thank you.
So my presentation will be basically, I will talk briefly about the historical background of the disease, the epidemiology, some basics of the clinics, and the public health impact. This disease was initially identified in Africa and Tanzania in the 50s, and after that it was spread all across almost the whole world, Africa, Asia, Europe, and the Americas. And as we are going to see today, is leading several outbreaks around the world. Many populations are suffering this disease, especially tropical areas where we will see there is a huge burden of disease, a high incidence of disease, and also a huge incidence of sequela which also impacts the public health. The symptoms initially are very difficult to differentiate from other arboviral diseases. You will see in the left side the acute infection, on the right side the chronic infection. But the hallmark of this disease is the arthralgia. So even though you may see several cases that are similar, like dengue or maybe Zika, the hallmark of this disease, on top of the fever, the malaise, and the body pain, is the arthralgia. And this arthralgia also impacts the public health, because the chronic arthralgia will impact the cost of the treatment of these patients all over their life. And we are seeing this at least in my region. We have a huge outbreak in Paraguay, in Brazil, and we are seeing these cases right now, and people are suffering because they didn't have the opportunity to have the vaccine there to prevent this disease. As I said, in some instances, the patients may experience persistent joint pain, and this can last for months and even years. And this, as I said, will impact their quality of life. And as you know, the quality of life is part of the public health impact that will drive the costs of this disease. The differential diagnosis, as I said, it can be confused by other diseases such as dengue or Zika. So it is very important for every site that handle these kind of cases or patients to have an accurate diagnosis in order to have a better follow-up and understand much better what is the case they are treating. The epidemiology, this is a recent update from Access in February 2025. There were reported over 30,000 cases and several deaths across 14 countries and territories. And also there have been cases reported in several countries across Latin America. The most affected countries were Brazil mainly, but also Paraguay and Argentina and Bolivia. Outside the Americas, we are seeing cases in Asia, in Pakistan, in Africa, and other countries in Africa. And I guess something is going to be told about, I think there's like an Italian case that has been reported recently. So there are also cases in Europe, and this is also a concern for other parts of the world and also North America. Even though no autochthonous case has been described in Europe, I believe there was a report recently from Italy. And also there have been cases in La Reunion where a huge outbreak occurred there, and also vaccination started there. So we are also looking forward to see the publications regarding the impact of this vaccination during this epidemic. Here we can see the notification of cases until January 2025. You can see obviously the biggest number of cases are in Brazil, but you can see also cases in North America, parts of Southeast Asia, Africa, and now we are starting to see cases in Europe as well. This is the incidence mostly in the Americas. So you can see the number of cases is increasing in the United States. And this is also a situation that is also concerning people who are traveling outside the country, but also you can see cases in the country. So that's also something that you should take care when you are seeing some patient with symptoms that can be similar to dengue or Zika. You need to think about chikungunya as well. So this disease, as I said, it places a significant burden of healthcare costs for the system of health, and particularly during the outbreaks that requires an increased medical resources. But the most important burden of cost is the chronic pain. So it had been estimated that almost 1.95 million deaths is the cause of this disease globally. And most of the burden is found, as I said, in Latin America and the Caribbean region. And over 10 years, the direct cost is at least 2 billion in direct costs and 47.1 billion in indirect costs worldwide. And the long-term chronic illness was the source of most costs of and dailies. So that's why I emphasize the importance of prevention and treatment of this disease. So to conclude, chikungunya is a significant public health issue. Effective prevention, early diagnosis, and community engagement are crucial to mitigate its impact. So I hand over to the next speaker. Thank you very much.
Thank you very much, Dr. Casellas, for your intervention. I will now give the microphone to Dr. Rebecca Christofferson. She will speak about the epidemiology and geographic expansion, the possibility to predict outbreaks, the environmental and vector-related indicators, potential risk of importation, through infected travelers. Thank you, Dr. Christofferson.
Thank you. So I'm going to present a little bit of the big picture of chikungunya today. So I do have some disclosures. Here's an outline. We'll talk a little bit more about epidemiology and drivers of transmission, and eventually get to prediction in the models used and importation and domestic risk. So these are the primary vectors of chikungunya. They're spread by Aedes aegypti. This is a mosquito that lives primarily in the tropics, a little bit in the subtropics. It is also the primary vector of both dengue and Zika. Aedes albopictus is the Asian tiger mosquito. It's also found in the tropics, but it is much more tolerant to temperate climates. So you will see it quite a bit more north than you would Aedes aegypti. And we have these year-round in the south of Louisiana, where I'm at, for example. So this is a graphic kind of showing, so chikungunya is believed to have evolved in southern Africa in a sylvatic cycle or a jungle cycle of non-human primates and arboreal mosquitoes. Eventually, at some point, it have emerged from the sylvan into an urban cycle with Aedes mosquitoes, especially Aedes aegypti. It was kind of off the radar until around 2005, when there was a giant outbreak of the Indian Ocean lineage, and this is kind of where that originated. So there's the Asian lineage, which is sort of the and the Indian Ocean lineage, which are sort of the historical, and then the ECSA lineage is this lineage that we think adapted more to Aedes albopictus, made Aedes albopictus more of a co-primary vector rather than a secondary vector, and then facilitated its spread to places like Southern Europe. So of course, after the Indian Ocean outbreak, then we had the spread into the Americas in the 2014, 2015, and since then it has been endemic across the tropics. So going back to the reservoir, the non-human primate reservoirs have been indicated through experimental inoculation to see if they get viremic, but also through serology. So we have some idea that some of these non-human primates can be viremic enough or get enough virus in their blood to transmit to mosquitoes. And then for a while there, we really thought Aedes aegypti was the end-all be-all. Again, with that La Reunion outbreak, there was an idea that Aedes albopictus was now the primary vector, because we did see that adaptation of the ECSA genotype to Aedes albopictus. However, when we looked at the data, the historical data available in 2014, we noticed that, yes, there was an adaptation of albopictus for the particular genotype. But if you looked at the data available, it didn't outcompete Aedes aegypti. It just got maybe as good as Aedes aegypti. And so a lot of times we sort of go with the shiny new finding. And so there was a lot of discussion about Aedes albopictus, and aegypti kind of got lost in the discussion about that. But when we did see that emergence in Brazil, for example, Aedes aegypti was implicated, at least, if not more so, than Aedes albopictus. Also going back to the reservoir picture, there's a old world versus new world non-human primate idea. We don't really know what the New World non-human primate reservoirs might be in this context. And also, so we've done some work in Southeast Asia where we've looked at non-human primates in Cambodia and Thailand that are proximal to human populations to see if there's exchange of virus. And what we found was that it was different. So in Thailand, we could see some serological evidence of chikungunya in non-human primates, whereas in Cambodia, we didn't see much at all. So there's also within region variability that we have to sort of understand if we're going to really get into predicting and forecasting. The other thing is through a series of experimental studies, we found that there are other things that may be probable or possible reservoirs. Bats, rodents, a handful of reptiles and amphibians have also been shown to be competent for viremia, but we don't know, of course, in the context of the ecology and the associated vectors, what that might look like for their roles as reservoirs, but it's worth looking at in the future. So this is the CDC. This is activity around the world historical. So the lighter blue is going to be just historically that there has been activity. The darker blue is going to be activity in the last 5 years. Of course, this hasn't been updated since we think there was a local transmission in Italy last week, but this is what it looks like at the moment. So when we talk about drivers of transmission with things like zoonoses or vector-borne diseases, we have to talk about environmental drivers of transmission. We also have to talk about how vector control plays into that. And then, of course, there's going to be human behaviors and other factors that are going to help shape what an outbreak looks like. So the first one is environmental. We have a lot of different things, but we're going to focus on temperature and humidity. So temperature plays a role in various different ways. So the first thing is that it directly impacts the way that the virus replicates within the vector. So mosquitoes are cold-blooded. They take on the ambient temperature of the environment, which means that the virus is experiencing that ambient temperature. In general, we tend to think of a higher temperature, the virus tends to replicate faster and get out of the mosquito faster. So that's one way that temperature can play with this system. However, when you look at life traits of mosquitoes, those are also temperature dependent. So we're going to think about things like hatching success, emergence time, survival of the adult mosquitoes. Those are all going to be relevant to things like mosquito density or how many mosquitoes per person there are. And these are all going to be temperature related. There tends to be sort of this little hump shape. There's an optimal temperature somewhere around 28. After that, it becomes too hot. They die quicker. They don't emerge as well. And you can kind of see this here. This is looking at biting rate. So if you look at the biting rate of mosquitoes, we see that same sort of temperature dependence. There's an optimum around 28, somewhere around 32 or 30, they get too hot and they just don't feel like doing anything. So they don't start to bite. And if you think about the way that these viruses are transmitted, that bite is absolutely necessary because you not only have the bite where the person gets chikungunya from that first mosquito, you need that second bite from a different mosquito to then propagate the virus in the system. So that's the way that we look at temperature on this system. Another thing that we're looking at is microclimate and land use. So when we're looking at models in particular, we like to use environmental covariates, and one of those is temperature. And so weather data, satellite data, all tends to be pretty readily available. But what we wanted to look at in this particular, I know other people are looking at it as well, is microclimate. So what we did was we deployed some paired thermometers. One was inside, one was directly outside the home, and in 3 areas in Colombia. And we saw that there was a difference in those 2 diurnal fluctuations. So when we then took that to the lab and made our mosquitoes experience those 2 temperatures, we saw that there was a difference in chikungunya vector competence. And when we put that then into a model, we were able to see that inside temperatures had a higher peak and a shorter time to peak for their epidemic curve than the outside temperatures did. And that's with no interventions, holding everything else constant. So that was just to kind of isolate whether or not microclimate could be impactful. When we talk about land use, one of the classic examples for chikungunya is that when you convert virgin forest to palm oil plantations, there was an influx of albopictus, and then we see almost a trailing increase in chikungunya as well. So we do see how land use, independent of other things, can change the ecology of that area, bring in the mosquitoes and bring in the diseases. So that's some of the ways that these factors can influence transmission. Something that's not looked at too much is photoperiod. So this is just the amount of sunlight a mosquito can experience. So Aedes aegypti and Aedes albopictus are dawn and dusk mosquitoes. They daytime bite. They do bite during the day as well, but primarily at dawn and dusk. So this researcher, Constanzo, also looked at how that affected their longevity. And what they found was that mosquitoes experiencing shorter days lived longer than the controller mosquitoes experiencing longer days. Did I say that right? Shorter days lived longer than longer days. They also found that females experiencing shorter days had more propensity to bite or take a blood meal than the other groups. So that's another impactful way this might affect that. So when you're talking about light pollution and things like that, that also has a role in sort of some of these ideas of transmission and interventions. And then finally, we have to talk about weather and climate, because it is, of course, related to temperature and humidity. We've always seen sort of this uptick in mosquito populations and association of outbreaks and cases with El Nino, which tends to be a very wet period compared to La Nina. Also, what we look at is seasonality of places. So this is more so for Aedes albopictus, where you have that sort of tolerance for temperate areas. So the mosquito will move upwards, and then it might do it so transiently. So it might only go to, let's say, El Paso every now and then, because otherwise it's too hot. Or we've seen albopictus as north as New York City. It won't be active there all the time because it gets quite cold, but there is a transient period of time where albopictus is there and available for, let's say, a returning traveler to come by and spark something out. So what we looked at was, how does that change? How does that seasonality or the window of opportunity for something like that to occur change with climate change? And so we looked at the worst case scenario, which is a 1.5 degrees Celsius, according to IPCC, and then some interim as well. And you can see that in places that are always permissive, it doesn't change anything. Puerto Rico is always going to be permissive pretty much throughout the year. But in Miami, New Orleans, and El Paso, we did see that there was some effect of the seasonality or the permissive window of outbreaks, depending on that warming, that average warming of the temperature. All right, so vector control, there's three main kind of ways that we look at vector control. There's others, it's not all of them, but these are the ones that I think are biggest or most relevant here. We have our personal protection measures. These are going to be things like bed nets, which are not deployed as much for Aedes aegypti, but it could be useful. Things like personal bug spray, permethrin treated clothing, educational programs, or just avoidance habits, things like that. We also have spraying, of course. There's aerial spraying. We in Louisiana have trucks that come by and spray. There's fogging of homes like this gentleman showing here. There's also residual indoor spraying, which is just sort of spraying of the walls where Aedes will rest, kind of makes them leave the house at that point. There's also vector-related things like Wolbachia, but I'm going to talk about GMO mosquitoes. So these are genetically modified mosquitoes. They're males, so they genetically modify the males. And the reason that's important is because males do not bite. So releasing males does not add to the mosquito biting of the population. And what happens is these males will mate with females, and that renders their progeny from that mating and future progeny unviable. They don't survive to adulthood. So it's a great way to sort of go in there and, do a quick population suppression moves, especially in fulminant outbreaks. Human behavior. So if we look at the amount of water that Aedes aegypti in particular need to lay eggs in, it's not a lot. So these are container breeders. They like to breed in bottle caps. They love tires, things like that. Pretty much opportunistically, we've demonstrated that they will lay in plastic bags that are holding water. They're really not that picky. So source reduction is just taking the source of water and dumping it out. That's all it is. So not having a place for these mosquitoes to lay their eggs and to breed and to, you know, make all these other baby mosquitoes in close proximity to where you're living, that's going to go a long way to sort of interrupting that opportunity for contact. Avoidance behavior is going to be some of those personal protective measures, but sometimes it's going to be not going outside at peak times. So for these mosquitoes, it's going to be dawn and dusk, or it's going to be just being aware that maybe you'd have to use a fly swatter or things like that. So just those kinds of behaviors. And then education and compliance. This is just educating people about the dangers of mosquitoes, the efficacy of things like source reduction and avoidance behavior, and sort of getting them on board. And of course, compliance is always necessary. So if you have something where you're going to instigate a source reduction effort, you need everybody to participate. Otherwise, you're still going to have mosquitoes. That's good if people are willing to take responsibility for their own yards. It becomes an issue when it becomes things like trash dumps or illegal tire dumping, those sorts of things. Then you're going to have issues with whose responsibility is for it and who's going to foot the bill. All right, so who's at risk for chikungunya? So obviously those who live in an Aedes endemic area, they're going to be at risk. Those who are at risk for exposure to chikungunya in occupational settings. So this could be lab workers. It could be people who work in areas that they are outside at dawn and dusk in those peak biting times. And then, of course, you're going to have frequent or long-term travelers to chikungunya at-risk regions. So people who spend an appreciable amount of time in these areas that are at risk for endemic transmission. So this is current and ongoing outbreaks as of 2025. India has not separated their 2024-25 data yet, so it looks probably worse than it is for just this year. La Reunion is still going strong. They've had some importations into Mayotte as well. Again, there is that case in Italy that we're still looking at to see if that's chikungunya. And then, of course, all of this has been associated with several deaths this year as well. So it's not a not fatal disease. Okay, so predicting outbreaks, how do we do that? Well, prediction in general starts with data collection. And then we have model development and then using those models to predict. So there's several tools that modelers use to make predictions. And I am not an expert in all of them, but we will go through them and I'll tell you what I know. So compartmental models are kind of the gold standard. This is used a lot to make predictions about what an outbreak might look like, used to test for and make predictions about the quality of an intervention or the efficacy of an intervention, excuse me. We also have statistical models. These are used for short forecasts. They can be used to kind of interrogate the specific impact of particular variables or parameters. The inference is usually good, but sometimes the extrapolation beyond the data is not great. It just depends on the quality of the data. Time series models are great for in the moment. They're very actionable. They require kind of consistent time series data to feed what's going to happen in the next time step. So these are great for how many cases do you think we'll have next week? Is it going to increase or decrease? It's used a lot in COVID for doing things like how many beds do I need in the ICU next week? So those kinds of things. Again, it is not great for extrapolating long-term, again, because you need that historical data, but it is very useful. And then we have spatial and spatial temporal models. These are great for visualization in particular. So these are used to map risk. You can look at clustering. You can look at speed of spread, direction of spread. These are, I think, probably mapping things is a really good way to get a point across to decision makers in particular. Agent-based models are kind of a very, very detailed version of other compartmental models. That's probably not correct, but in my head, they're abstract related. So agent-based models is every single person, for example, or every single mosquito, for example, is an agent, and you model their movement accordingly. So it's very computationally expensive. The assumptions in the model kind of compound, but they're really good for tracking things on small scales. You can scale it up, just gets really big and expensive, but it does have its use. And then finally, we have ecological niche models. These are really important for looking at environmental suitability. These are basically use environmental covariates to determine whether something whether an area is permissive or not. It does have an assumption of presence of a case, for example, implies suitability, where that may not always be the case, especially when we're talking about importations. So machine learning, which I had kind of in statistical modeling, just that's kind of a nod to my stats background. This is great, and it's getting a lot of traction. These are great for recognizing patterns, especially complex patterns in data. This is great for classifying areas or classifying situations for yes, no outbreak, fast outbreak, slow outbreak, those types of things. It can handle large data. Some of them can handle pretty messy data. But some of them are a black box. Some of the machine learning algorithms are a black box. And so taking them, making the inference from them gets a little muddy at times. They do require a lot of data usually, and the data cleaning part is pretty intensive. So it can be not as computationally expensive, but it is personnel and resource expensive. But still a really cool tool. But all of that needs data. So if you look at our historical, this is a paper that looked at references on chikungunya from 1999 onward. So if you look in Africa, we had that Indian Ocean outbreak, and then we started to see more. And then if you look at Asia, this is when we had that 2008 outbreak, you start to see more. And then you look at the Americas, then we had to wait till we had an outbreak here, then you start to see more. So this shows you that we are very reactive in our publication and our research. Part of that's probably because we're reactive in our funding. So what happens here is that we have data that feeds a bunch of reactive sort of predictions. So we're still trying to play catch up and determine, okay, what could we have collected over here to get us to here? So we still need more data. We are constantly in need of more data to determine which model is going to help us predict certain types of outbreaks and not just those huge booms outbreaks. Okay, so yes. So importation and domestic risk. We have importations pretty regularly into the United States, into South Europe. We have mosquitoes in the south of the US that are competent for chikungunya. And Florida does a really good job of keeping track of travelers that return. They have a really good newsletter that it's access free. You can go get that information. The thing about the US is that we have really good infrastructure to avoid mosquitoes. We mostly use air conditioning. We have screens on our windows. We do have access to bug spray that's pretty available. So we sort of already have that avoidance and interruption culture. However, we do have a border force buildup that's occurring right now. So we are putting naive troops or presumably naive troops in close proximity to chikungunya at-risk areas. So the border between Mexico and the US, where we have had transient transmission before. We also have to think about disaster-related interruption of our services. So in Louisiana, we get hurricanes, and after hurricanes, we always get a mosquito bloom because we have an interruption of those vector control strategies. So that we really, really do want education and awareness of these vector-borne viruses to be part of disaster recovery efforts. So why do we predict outbreaks? Well, for resource allocation, if you can tell us where or how bad something's going to be, then places that don't spray all the time will be able to more efficiently allocate when and where they're going to spray. I can tell you that vaccine trial logistics, if you're designing a randomized clinical trial, that takes a lot of on-the-ground logistics and infrastructure. So you want to be as sure as possible that where you set this big operation up is actually going to experience the outbreak that you need it to get those cases and have power for your vaccine trial. And then, of course, predicting outbreaks is good for science communication, not only to the lay public and lay audiences, but to decision makers and to funding agencies as well. So there's a reason across sectors as well. And this is just finally, I think we have an understanding of that we need data to do predictions. I think what we really need to press on is that we need to continuously update our data to continue making predictions, because what we think we know about chikungunya as it exists today in a system of the globe is going to change, because the globe is going to change, or the land use is going to change, the climate is going to change, human mobility is going to change. So all of that is going to change. So we just need to keep updating our data in order to make sure that our predictions remain relevant. So I saw Alejo's hand go up, but good news, I'm done. So thank y'all.
Thank you very much, Dr. Christofferson. That was very, very insightful. I will now give the floor to Dr. Chan. She will speak about chronic chikungunya disease, the role of mosquito avoidance measures and vaccination as prevention methods, including challenges to mosquito avoidance and effectiveness. Dr. Chang, the floor is yours. Thank you.
Thank you. Can you hear me and see my screen? Okay, great. Hi, it's very nice to have you today. Thank you for joining us. I'm Associate Professor of Medicine at George Washington University, and my research focuses on chronic chikungunya disease, and I'll talk to you about that today. So today I'll talk about chikungunya viral-induced arthritis and also prevention methods. So here's a picture you can see from the Dominican Republic in 2014. And these are very characteristic pictures of the arthritis that you may anticipate from chikungunya infection. So chikungunya means that is bent up in the Makande Tanzanian language. And you can see these patients have severe arthritic pain. Here's a picture from one of the patients from our Colombian cohort. And you can see the severe arthritis that he experiences. In patients after chikungunya, some patients may have a relapse of rheumatic symptoms, and this may include polyarthralgias, polyarthritis, tenosynovitis, and multiple other symptoms in the months following acute illness. We found that about a fourth of patients have arthritis about 2 years after infection, and this can be chronic or relapsing and remitting. And we even have a large cohort of patients who, even 10 years after their initial infection, still suffer from arthritis after chikungunya infection. We performed a study of persistent pain 20 months after chikungunya infection and found that approximately 1/4 had persistent joint pain that was attributed to chikungunya infection. So there have been multiple groups that have looked at predictors of chronic arthritis. So a few of them include severity. So an initially more severe infection with an initial number of joints, a higher number of joints with arthritis, initial higher pain scores, initial missed work, and initial normal activities affected are more likely to cause chronic arthritis afterwards. In addition, initial infections that have a longer duration are usually characterized by or predict long-term arthritis afterwards. So if the patient has over 4 days of initial chikungunya acute viral infection or over 4 weeks of initial joint pain, they're more likely to have long-term arthritis. And also, female sex is also associated with long-term arthritis. And we see this in our cohorts where over 80% of the cohort of patients with chronic chikungunya arthritis are females. And this is seen also in cohorts around the world. Here you can see a graph of months post-infection and the prevalence of disease. This is data from 16 cohort studies that showed an average rate of arthralgia resolution of approximately 10% per month. So the expected median time to arthralgia resolution is approximately 6 months. So oftentimes patients will ask when they're in month 1 or month 2 after chikungunya with horrible arthritis that's affecting their work. How long is this going to last, doctor? And the answer is that the median is about 6 months. But there are multiple people who continue to experience arthritis that may last for multiple years. And at this point, we really don't know what predicts those patients who will become patients who have arthritis for 5 or 10 years after their initial infection. The expected arthralgia prevalence is approximately 72% at 3 months post chikungunya infection. And this has major public health implications. If you think about a outbreak, for example, with an attack rate of 30% of the population, you can expect 3 months post chikungunya infection, you will still have significant arthralgias and missed work in approximately 70% of the population. So this is something that is also important to model when we consider our public health implications of a chikungunya epidemic. So after we did our first studies looking at the the prevalence of arthritis and some of the risk factors, we really wanted to better understand what the mechanism of chikungunya arthritis was. So we were funded by the Rheumatology Research Foundation to determine if chikungunya persists in synovial fluid post-infection, potentially serving as a causative mechanism of persistent arthritis. So here you can see a picture of some of the patients that participated in our cohort. You can see many of them are women. In terms of the patient population, for an arthritis cohort, these patients are rather young. The mean age was 56. Most of them are female, as I mentioned. This is a Colombian cohort, so we had Afro-Colombian and white Colombian ethnicities. And the vast majority of these patients did not have any type of arthritis prior to infection with chikungunya. We do though see that patients who have pre-existing arthritis or osteoarthritis or rheumatoid arthritis may suffer more after a chikungunya infection from the arthritis. And there are quite a few patients that had hypertension in both groups. These patients experienced significant disability. So over 80% reported an effect on their activities of daily life. Approximately a third reported missing work or school. And the disability mirrors that of rheumatoid arthritis. So the average tender joint count was about 5, and the average swollen joint count was about 3. We do see, though, that with chikungunya arthritis, we see less swelling as opposed to tender joints. And when you look on ultrasounds, you do see microvascular changes and swelling on ultrasound, but not frank swelling in the same way that we see with rheumatoid arthritis. But when you measure a disease activity score that's used for rheumatoid arthritis, we do see approximately moderate disease activity in these patients with chikungunya arthritis. And we have recently developed a new scoring system that is specific to chikungunya and the joints that are affected in chikungunya to better be able to measure disability in chikungunya. So with this study, we drew synovial fluid from the knees of affected joints, from the knees of patients who had their knee affected during chikungunya infection and had pain in those knees. And we looked for the virus. And so we did PCR to look for viral RNA. We did mass spectrophotometry to look for viral proteins, and we did culture to look for virus that we could grow live virus. And all of those were negative. So that led us to the conclusion that likely chikungunya arthritis is not due to a continued viral reservoir of live virus, but rather this is an autoimmune response to RNA or virus that had infected the joint prior. So we wanted to, so we've spent like the last 10 years considering what are the potential mechanisms and how can we treat this. So in terms of being residual virus, there really has not been evidence to demonstrate that there is residual live virus that can be found in the joint. There are some studies that are able to demonstrate retained RNA within the synovial tissue or within macrophages, but no one to date has found live virus, culturable virus in viral reservoirs, for example, in the joint. So another question we had was, could this potentially be antibody mediated? So we looked at common autoantibodies in rheumatoid arthritis, for example, like rheumatoid factor, anti-CCP, anti-CEP. Some antibodies that have been thought to play a role in chikungunya, like anti-vimentin or anti-SA, and also ANAs, like we might find in lupus. And all of those were not related to disease activity in chikungunya arthritis. So is it possible that there are other antibodies that are new to discover that play a role? That is certainly possible, but at least the common autoantibodies that play a role in rheumatoid arthritis are likely not playing a significant role in chikungunya arthritis. So I show this picture here because it appears that chikungunya arthritis is likely T-cell mediated. And this is a picture of the synovium from one of our mice that we infected with chikungunya in our chikungunya arthritis mouse model. And you can see here the extensive infiltration of lymphocytes in that blue color there. And the normal synovium, you would see very much less blue, and it would be mostly pink. So all of those lymphocytes and T cells appear to be causing an inflammatory reaction and contributing to chikungunya arthritis. And in fact, in mouse models, the presence of T cells is obligatory for the development of arthritis. So this may inform our future therapies for chikungunya arthritis. Right now, there is no evidence-based standard regimen for chikungunya arthritis. There are various empiric therapies that are currently used. Usually first line is NSAIDs. Second line is oftentimes steroids like prednisone. Some things that have been used are hydroxychloroquine, sulfasalazine, chloroquine, homeopathic medications, ribavirin, and methotrexate. Some immunosuppressive therapies, particularly methotrexate, may provide symptom relief in chikungunya arthritis. However, there's been a lot of study heterogeneity and limited randomized trials to restrict definite conclusions. We are performing the first phase 3 placebo-controlled randomized controlled trial of methotrexate monotherapy in Colombia that's funded by the National Institute of Health, and hoping to further define the value of methotrexate in the treatment of chikungunya arthritis. Examination of the use of disease-modifying biologics is limited, and we're currently also examining the role of low-dose interleukin-2 therapies to augment regulatory T cells and decrease effector T cell activity, hoping to kind of get at that T cell mediated potential mechanism of chikungunya arthritis. So now I'll quickly go over some of the prevention mechanisms and move to talk a little bit about the vaccine as a potential mechanism for prevention. So to date, prevention has focused mostly on mosquitoes. So vector control, as Dr. Christofferson mentioned, personal protective measures, and community risk mitigation. So here are examples of some of the personal and home measures that may be taken. And what I'm going to talk about now is how these don't always really work very well, and they don't always prevent epidemics. And the reason is, so for example, you have there on the right your bed net. And the bed net is a great tool, but with our Aedes mosquito, as Dr. Christofferson showed, it bites during the day and at dawn and dusk when you wouldn't be under a bed net. So oftentimes bed nets are not really very helpful. And then there's all these other personal protective measures like repellent and you know, the zapper, as I like to call that tennis racket looking thing. And you know, these things are helpful. And if you live in an endemic area, it's not uncommon if you think I'm going to go out hiking or something, I'll put on some bug spray. But in real life, most people don't wake up and put on bug spray every day that they're in their house or in their neighborhood in an endemic area. So it's really not particularly valuable for a lot of the transmission that occurs around your home on a daily basis. And then we see things like air conditioning and screens are very effective in preventing mosquito bites, but only if you are of a socioeconomic status where you're able to have those things and to afford to have those things on whenever you're in the house. So not everyone in the world is able to afford housing that has air conditioning and that has screens as well. So that doesn't really work for all of the endemic areas. And then the fumigation programs, as Dr. Christofferson talked about, are great, but they only get the adult mosquitoes, and you have to have a lot of government involvement in order to have those the fumigation be consistent and regular. And here is another picture of community measures, like cleaning up standing water so they don't become sites of viral replication and mosquito replication. And then you can see in the middle is a picture where a public health officer is putting larvicide into a water container. So in many parts of the world, people don't have access to potable water that is continuous, so they guard water and save water in large containers, and these containers can become breeding sites for mosquitoes. So putting larvicides in there can be helpful, but that is also something that has to be done regularly. And given that the Aedes mosquito can breed in a amount of water that is in the top of a soda bottle cap, it's really, really a challenge. I have 2 young children and I'm a mosquito expert, and I go in my backyard and I realize how many toys are sitting in the back there filled with water and serving as mosquito breeding sites. And I have all the motivation to clear it, but the reality of being able to keep your home clear of any mosquito breeding sites is really a challenge, particularly if you have really beautiful gardens that can often serve as very easy places for mosquitoes to breed if they have any nooks and crannies where water can be saved. So luckily, we now have another tool, which are the chikungunya vaccines. And this is information from the US. So there's 2 vaccines. The first vaccine to be approved is IXCHIQ, which was produced by Valneva and was approved in 2023. This is a live attenuated virus, and it's approved currently in adults over the age of 18, and they're currently under review for children over the age of 12. And this is a single dose vaccine. More recently, in February, Chikungunya, which is made by Bavarian Nordic, was approved this February of this year. And this is a virus-like particle vaccine that is non-replicating, and it is currently approved in individuals over 12 years of age. It is also a single-dose vaccine. There are multiple benefits of chikungunya vaccination. So some of them include that they could prevent debilitating disease, like I talked about. Because if you can think about some of the factors for chronic arthritis, some of those factors are having a very robust initial infection. So if you can prevent having that robust initial infection, then you can reduce the likelihood of having long-term joint pain. Chikungunya vaccination also protects high-risk populations, and we'll talk about in the next slide the outbreak in Réunion Island, the French department in the Indian Ocean. And the high-risk populations are those over the age of 65. The deaths that we have seen there have predominantly been in patients over the age of 70. And then it also very sadly, we've seen severe disease in 21 infants. So in terms of high-risk populations, we think about the young and the old. And those are people that we definitely need to think about protecting. And in addition, we want to think about protecting those that are responding to outbreaks and those that are endemic residents in areas where there is ongoing transmission. And also, it's very important that we think about protection in women for a few reasons. Women, as you saw in my presentation, are much more likely to develop chronic arthritis. And in addition, women of childbearing age have the possibility, if they are pregnant, to have vertical transmission. And we have seen in prior outbreaks that a woman infected with chikungunya at the time of giving birth has approximately a 50% chance of vertical transmission to the infant. And in those infants that are infected via vertical transmission, about 50% of them have severe, persistent, lifelong disabilities. So it is extremely important to consider women when you think about high-risk populations that could be potentially protected by a vaccine. The other group that I hadn't put on this slide is also laboratory workers. While it may be a smaller group, there are, in my lab, for example, we work with chikungunya, so it's great if laboratory workers who have exposure to chikungunya can become vaccinated. Another benefit of chikungunya vaccination is that it supports outbreak response. So on the next slide, we'll talk about how Valneva provided vaccine to La Reunion Island and help with the vaccine, with the outbreak response. And as we know, not only does it prevent the case in the individual, may prevent the case in the individual, but also the spread. Because if that individual doesn't become infected, they can't then spread it with a bite from another mosquito to another person. So you may see exponential decreases in chikungunya spread with vaccination. In fact, there was just a lovely publication that came out of Paraguay that modeled the vaccination if vaccination had been used during their large outbreak that affected 30% of the population. And if vaccination had been used, then they could have decreased the number of deaths by 73 deaths. So certainly there's a massive potential benefit for using chikungunya vaccination during outbreak responses. In addition, you can expect decreased healthcare burden. So for all those patients, you don't have the severe cases that you're taking care of in the ICU, and then you also don't have the long-term arthritis afterwards that in 70% of the population, 3 months afterwards, that you have to find resources to care for those patients and also consider the economic impact of all those missed days of work for those patients. And lastly, it will advance global preparedness and we'll be able to better respond to emerging arboviral threats. As a note, chikungunya virus is not the only arbovirus that causes arthralgias, and there's multiple other viruses in this class. So being able to have one vaccine may actually have some cross protection for other viruses, arthrogenic arboviruses as well. And this is my last slide, and I just wanted to bring to light some of the cases that we've been seeing in Reunion Island in the Indian Ocean. And since the beginning of 2025, there have been over 44,000 cases reported and 9 virus-related deaths, and those were in patients over the age of 70. And as I mentioned, 21 infants with critical severe chikungunya. So we're currently in an epidemic there that is spreading to Mayotte and Mauritius. And so Valneva provided 40,000 IXCHIQ vaccines to Reunion Island to help battle the epidemic, and hope that that can help curb the epidemic somewhat. Thank you very much for your time.
Thank you, Dr. Chang. A lot of information throughout these 3 first sessions. And now I'm going to give the microphone to Dr. Chacon, who is going to lead the Q&A. He has some questions for our experts, and you have the floor, Dr. Chacon.
Thank you, Felicitas. Well, indeed, chikungunya is an increasing public health problem globally. We didn't hear about chikungunya many years ago, and now it's becoming a real problem with, many more countries with medium-high endemicity And worse, we're having a lot of outbreaks. And all of this has been very well explained by our three speakers. I will say master explained. And yes, the thing is, we have tools to prevent this disease, not only with the typical mosquito-related preventive methods, but also we have vaccination. Well, now we need to go further with the questions. We have a very good one here, and I think I'm going to ask that to Dr. Casellas, since he's an expert in surveillance for infectious diseases. The question is, could the lack of cases in Africa, especially East Africa, where chikungunya the virus was first isolated, be due to the lack of an effective surveillance system, hence underreporting?
Thanks, Enrique. Yes, I was reading the question as soon as it was written. Yes, I believe that is a very good point. Obviously, surveillance is a key um, way of not only making diagnosis, also handling outbreaks. So if you don't know you are having this kind of disease ongoing and you don't have the ways to diagnose the disease, you can have outbreaks as the one we are seeing or witnessing in La Reunion. So I guess, yes, unfortunately, we need to support countries in order to get the best way to diagnose not only this kind of mosquito disease, but other diseases as well.
Great.
Back to you.
Yeah, thank you. So I'm going to open another few questions that I have here. I think it's going to be for Dr. Christofferson. This may be a hard one. Do you think chikungunya virus is still underappreciated in global health policy?
Yes. I think you can see that with the fact that most of our published literature happens after outbreaks. You'll see another spike in literature after this La Reunion outbreak, I'm sure. So yes, I think vector-borne viruses in general, but chikungunya certainly.
And following that question, what's your take on the continued relevance of Aedes albopicus in future outbreaks, since albopicus, is the one that likes going further north or further south?
Yeah, so I think as long as we appreciate in tropical regions that there's Aedes aegypti as well, which I think most people do, I think we definitely need to pay attention to the expansion of Aedes albopictus in the shorter term compared to Aedes aegypti, just because it's already in a lot of these temperate places. Like I showed, that seasonality is going to lengthen, and you're going to have more of an opportunity for sporadic chikungunya cases to occur in these more temperate areas, especially as we have warming of seasons and lengthier, warmer summers. Eventually, we'll also have to worry about the expansion of Aedes aegypti north as we get, warm enough for it to survive as well. But in the shorter term, and short being many years, Aedes albopictus is going to be sort of the creeper along that brings it into more naive populations, such as the southern United States, the middle of the United States, and southern Europe.
Yeah, that's very interesting indeed. Now, regarding the vaccines, because both you, Dr. Christofferson, and Dr. Tian have mentioned that non-vaccine preventive measures are good, but not enough. So, Dr. Tian, a few questions that I think the audience will be really appreciative to know is related to the vaccine. So, what is the length of protection of immunity by, in this case, the Valneva's live attenuated vaccine? So far, what we know,
Yeah, what we know so far. So live attenuated vaccines oftentimes have very strong immunogenicity and long-term protection. That said, because the vaccine is new, it's only been followed out thus far 36 months. So we know that it provides protection for 36 months, but it is likely that it provides longer protection, and we'll be following those patients to see exactly how long it lasts. But it would not be unthinkable that you would see protection over 10 years with a live attenuated vaccine.
Perfect. Yeah, that's a great answer. And it reminds me about all the other live attenuated vaccines like varicella, measles, moms that, we have lifelong protection. You're right, yes. But we need to see and wait for the data, Dr. Christopherson, Dr. Chang, and I live in the US, but many people in Europe are also interested in this question because most of their cases are imported. So the logical question is for travelers. What is the best time to get the live attenuated vaccine or the chikungunya vaccine before departure, and why?
So this is a really important point, and perhaps maybe in other countries access to clinical medicine is better, but in my clinic, my patients oftentimes wait 3 months to get an appointment or 6 months to get an appointment. And then so they send me a message, oh, I'm going to La Reunion, for example, in a week. And really what we want to tell our patients is if they are going to get chikungunya vaccination, they need to be vaccinated 2 weeks before they go on their trip. So really trying to get them into the clinic so that they can get that vaccine, or to any place that, a traveler's clinic that can provide the vaccine. But certainly the patient who gets it the day before they go is not ideal because they won't benefit from that protection unless they're going to be there an extended period of time. Most people are only traveling for a few weeks, so definitely making sure that they get scheduled and come in advance. So when my patients come, I ask them, are you planning any travel this year? And when they say, oh yeah, later on this year, I'm going to go have this. Oh, great. This is a great time to vaccinate you now before you go on your trip.
Yes, that's an excellent response. And not only for, in order to acquire protection, in order to produce enough memory cells and antibodies, but also the side effects. Usually the side effects related to, or the early side effects related to chikungunya vaccine occurred within the 5-7 days following vaccination. So you don't want to have, pain or, fever or low-grade fever in your vacation. So yeah, 2 weeks. Yes, thank you. And maybe the last questions, unless we have more from the audience. Yeah, we have another one. But just another question related to the vaccine. Can the live attenuated vaccine for chikungunya can be co-administered with the current dengue vaccine?
Yeah, so a lot of people will want to travel to an area that may be endemic for both chikungunya and dengue, but currently they cannot be co-administered because those studies have not been done yet. So they do need some space in between those vaccines. Excellent.
There's another question just appeared in the chat here, and it's not in the QA, but it says that, can you give the live attenuated Valneva vaccine for chikungunya co-administered with the yellow fever vaccine? It's the same question, but
yeah, unfortunately, those studies have not yet been done. And particularly since those are 2 live attenuated vaccines, it wouldn't be recommended until the studies are done.
Yeah, indeed. And the yellow fever vaccine has a lot of issues. We know pregnant women, the elderly, so. Okay, that's a great response. And the person who asked about the why we don't have a lot of data from East Africa is asking again. He's saying, I appreciate the current progress in vaccine development. However, I know that we currently lack vaccines for under 5 years of age. These infants are likely to develop severe disease, including neurological involvement. In his study in Kenya, they observed that this age group is disproportionately affected. Okay, what could be your take on this? That's a hard question.
Yeah, so there's a few ways to kind of to approach this. For those under the age of 5, Bavarian Nordic is currently doing studies to look in that population to see if the VLP vaccine would be appropriate and safe for that population. So hopefully that will be available soon, that data. And then when you think about the infant population, really the best way would be to vaccinate women before they become pregnant. Currently, there are some plans to do vaccination trials in pregnant women, but that's obviously a complicated trial to complete. And so the best thing to do is to think about women who are planning to become pregnant, who are planning to go. In the US, they have this baby moon phenomena where everyone wants to go travel to the beach before they have their babies. So making sure that we vaccinate people before they're pregnant can kind of prevent that vertical transmission and those infants from becoming infected.
Yeah, if you think about the transmission of these Aedes vectored viruses, we know that transmission occurs at the household level. So people move the virus doesn't go via mosquito from house to house. So you get sort of like this focal herd immunities. So we protect the infants by protecting the adults.
Yeah, that is a great response, actually. Yeah. Yeah. And for travelers will be the same advice. Yes. Sure. And let's wait for the data in you know, of the vaccines in younger ages.
Enrique, I have a
Yeah,
question.
Javier, yes.
So, Dr. Chang, I know how tough it is to vaccinate travelers before the trip. They usually go in the last minute. But I was just thinking, making a parallelism between measles vaccine and in this vaccine. So, what if, what do we know about post-exposure vaccination, early vaccination after exposure, and also maybe even vaccinating before or below the 14 days can be effective? I don't know, what are your thoughts about that?
Yes. So we don't have much data on post-exposure vaccination. Chikungunya causes a robust immune response rather rapidly after chikungunya infection. And because the vaccination does take time in order to, you know, similar to because it's instead of being live attenuated, you're getting the live vaccination or the live virus. You would probably see it around the same time, the immune response. So it probably wouldn't help afterwards. We really need to get to the patients before they get infected. But the valuable thing is say one person in the household gets infected with chikungunya, then you do have the chance perhaps to vaccinate people who haven't already been exposed to chikungunya but are likely to get exposed. So that's really a place where we could have a massive benefit of vaccination in an epidemic environment. And your second question, sorry, could you repeat that again?
Oh, I was just trying to reinforce, even though we will advise travelers to receive the vaccine 14 days prior to the trip, I will not tell them not to receive the vaccine if they call us, I don't know, 2 days before, because you don't know when they're going to get infected, right?
Yeah, exactly. I would, especially because someone who travels to endemic areas may travel again in the next 10 years or during their lifetime. So I would never turn someone down who is interested in vaccination. And they may not get the full, 98% seroprevalence protection, seroprotection, but they may still get some of that, particularly for later in their trip. So definitely still worth it to get vaccinated.
Thank you very much.
I will also like to ask this, because the incidence of chikungunya is variable, but all of a sudden we see outbreaks. So given the within region variability in the vector and its host dynamics, how do we avoid overgeneralizing the risk? I don't know, maybe Dr. Christopherson can respond to that.
Overgeneralizing the risk from place to place. Yeah, I think you have to look at risk.
Yes, I'm sorry.
Situationally. So I think there's going to be a global risk. You are either in a suitable area that's prone to outbreaks or not, right? That's going to be one level. And then there can be certain things that lead to, a transient outbreak or a sporadic cluster of cases here and there. There's going to be so many things involved with that. That's going to be sort of the standard statistician answer of it depends. But that's also why when you're looking at which tools to use, you need to be careful of overfitting or or using a model that's so specific to where you are that you can't then pick it up and move it to somewhere else, or just to know that you can't pick it up and move it. If you have a model that works great where you are, then leave it alone. But don't try and use it somewhere completely different. That's why you have to look at the entire system of the environment, the mobility of the people, the habits of the people, how prone are they to use some of these protective measures, or how prone are they not. The other thing you do have to look at is, going back to the question about East Africa, is your ability to see these cases as chikungunya, right? So like Dr. Casillas was saying, it looks like a lot of other things. So in East Africa, I would imagine that at least some of the people who go in with a fever and are diagnosed with malaria probably have chikungunya. In places where, there's dengue, at first we thought a lot of these chick cases were dengue, or they were Zika or whatever. So it's important to understand the dynamics of co-occurring diseases that look the same, because that's also going to be a big factor into, especially when you do syndromic surveillance, where you're relying on these clinical presentations to sort of spark your, to tell you that there's an outbreak going on.
That's an excellent response. Well, so before I hand over to Felicitas, first of all, I'm going to appreciate the time from all the audience and also the future audience, because this webinar will be permanently in the Vaccines Beat website, so everybody can actually access to it and see the webinar. I also thank profoundly the three speakers, experts in the field. I personally think that chikungunya is still underestimated. We need more research and more funding globally, and we're still seeing inequity in research and funding. That's what I see. And we need to vaccinate people, not only travelers. We need to find the gaps and the pros and cons, when and who to vaccinate in high endemic countries. We still don't know that. We need to figure it out. But we need more research and more funding. But again, thank you so much. I will hand it over to Felicitas.
Yeah, thank you, everybody. And I will reiterate our appreciation to Dr. Christofferson, Dr. Chang, Dr. Casellas, and of course, Enrique Chacon. And on behalf of our sponsors and the expert panel, we thank our audience for joining us today, for contributing to this vital conversation on chikungunya. We certainly hope the insights shared have deepened your understanding of the risks and responses needed in this evolving landscape. As a reminder, as Dr. Chacon mentioned, the recording of this webinar will be available permanently at the Vaccines Beat website, vaccinesbeat.org. Thank you again for being part of this important dialogue. We certainly look forward to welcoming you to future webinars. Please join our LinkedIn community and stay tuned. Thank you.